Okay, so this patient is a 53-year-old white female that I saw in clinic, and it was about a month and a half ago that I saw her. So the vitals when she came in, her blood pressure was 122/70 with a pulse of 96 and a respiratory rate of 16. The only other physical exam finding that day, she did have some expiratory wheezing from her COPD. That was it that was significant. So for her HPI, so she has been coming to our clinic for a long time. She's a longstanding patient. She has been hoping to get treatment for her hepatitis C for a while, but she has had a hard time with her sobriety. So she feels like she's in a good place now, so kind of wanted to pursue that at this point. She was first diagnosed with hepatitis C in 2018 in our system in February through a screening. She did her risk factors. She did use IV drugs in 2016 and intranasal drugs from 2010 to 2020. Her drugs that she would normally go to were opioids and cocaine, and her last use of cocaine was 8 months ago. She is in a MAT program, not the one through our clinic, but one of the local programs. She said she's been doing really well with it, and has been on Suboxone for that 5 years doing well. She does have some tattoos and piercings. They've all been professionally done. She has drank socially in the past, no alcohol use currently. Her last drink was in 2004. She does continue to smoke cigarettes, about half a pack a day, and she has a 44-pack year history. So her comorbidities include COPD, bipolar disorder, depression, dyslipidemia, GERD, and peripheral artery disease, and she has an iliac artery stent in for that. Her daily medications, she is on Suboxone 8 milligrams daily. She's on gabapentin for her neuropathy. She's on Protonix for GERD. She takes Miralax and Senna every day for her constipation secondary to the Suboxone. She's on Pravastatin. She takes aspirin and Plavix because of her stent. She is on Symbicort and Spiriva for her COPD. She is on Zyrtec for allergies, Prozac for her mood, and Seroquel for her mood as well. So as far as her hepatitis vaccinations, she has received one of the 2 hepatitis A vaccines, and her hepatitis A IgG was reactive. For hepatitis B, she has received vaccines and her surface antibody is positive. So she is 60 inches tall with a BMI of 22.8. For her lab work that she got in March, her CBC was unremarkable with a platelet count of 186. Her creatinine was 1.22. Her baseline over the last year, she's ranged between 1.05 to 1.5, but the most recent 3 values of 1.2, she's had one done since then, 1.18 as well. So it's pretty stable there. Her sugar was 156. Her PT and INR were both normal. Her albumin was normal. AST and ALT were mild. Her AST was elevated at 58 and ALT was 53. Her alk-phos is 71. Her T-Billy was normal. Her APRI was 0.76, CTP of 5, and a MELD score of 8. Her vitamin D level was good at 55. Her HIV antibody was negative. She is genotype 2. Her viral load was 4,500,000, and her fiber score was 0.22, which correlated to F0 to F1. So my questions, I wanted to talk about kind of the potential drug interactions, and she does take a decent amount of medications. And then through the algorithm with WV Medicaid, I was seeing maybe Mavorite or Epclusa.
Great, thank you so much, Jessica. That was a great job. I know presenting can feel a little bit overwhelming at times, even for Mitra and myself when we're facilitating. But you did a really great job. Does anybody have any recommendations that they would like to share?
Hi, this is Kaylee. You did a great job, Jessica. I'm going to recommend that Rachel talk about drug interaction because she'll do a better job at it than me.
Well, I don't know about all that. Also, I apologize. I'm on a different laptop. I actually did this so I can have a video today of myself, and I don't know how to work any of it. But as far as the drug interactions go, looking at these, you're correct. West Virginia Medicaid, Epclusa, Mavorite are definitely going to be your options, but maybe some finagling with the drug interactions here. Which will be a great segue into my didactic here in a few minutes. But the Protonix or pantoprazole is going to be the issue with the Epclusa. So with Epclusa specifically, it's omeprazole 20 or nothing. They don't recommend any other PPIs. So there's specific administrations to counsel the patient on with the omeprazole 20 milligrams with Epclusa, and they have to take them, the Epclusa and the omeprazole, I'm sorry, getting myself all worked up here. They have to take the Epclusa with food, and then they have to take the omeprazole 4 hours later. Okay, so sometimes that kind of gets in the way from a compliance issue because they're getting off their normal routine and like whether they usually take things with food or not. But that's the way they studied it from a pharmacokinetic standpoint. So that's what they see what works, even though it kind of sounds weird. Or, you know, if they don't clinically need the PPI, a lot of times we just trial that with patients and say, why don't you just hold off and see, you know, if you don't need to take it at all, then you don't have to worry about it. The other issue is going to be, looking at here, the pravastatin, depending on which therapy you decide to go with. So from a drug interaction standpoint, with the Epclusa, not so much worried about that one. So not really worried about dose reductions or anything. But if you would go with Mavorite in that instance, the recommendation, depending on which country you want to go with, in the United States, they say reduce it by 50%, that dose. I think in Europe, the max is 20 milligrams. They say no more than 20 milligrams of pravastatin with that one. Okay. You know, another alternative, depending on this patient's cardiac history, which we do frequently, is just hold the pravastatin. It's just 8 weeks. So if they don't have a significant cardiac history, we'll just say, you know, hold on to it, hold off on it, put it aside, take your Mavorite, and then when you're done, you can go ahead and take the pravastatin. The Mavorite itself has a short half-life, so there's not really a long like washout or concern. They can literally start it the next day from that standpoint. And then the only other one on here just to mention, but not really anything to do with it, is the Seroquel or the quetiapine that they're taking. It has sort of a narrow therapeutic window, so they just worry about some toxicities with that being, the concentration being increased with that, and primarily with Mavorite. You know, there's no dose change recommendations or anything, and I've had people take both medications concomitantly and not have any issues. We just tell them, you know, monitor for any of those sort of toxicities, CNS, depression, things like that. But most people do fine. It's just kind of a, you know, watch and be careful with that, with the Mavorite specifically with it. Okay. So I don't think that either one drug from a drug interaction standpoint is going to be a major issue. It's just how much do you want, you know, how much do you and the patient want to change to try to work around those, what they're willing to stop or hold.
Okay, thank you.
Mm-hmm. Thank you so much for that feedback. Does anybody else have any questions or suggestions they would like to provide us? Do you have any further questions, Jess? Are you good?
No, I don't.
Are you sure? Okay. Perfect. No worries. All right. So I think we can move on to our didactic, and that will be with Dr. Mitchell. And are you able to pull up those slides and share? I made you a co-host, but I am happy to do it on my end as well.
All right. So I've got two different screens here now. So I'm hoping this is the one you guys can see.
Yes,
Okay.
definitely.
So then if I make it bigger, maybe?
That one. Mhm.
Okay. All right. So yeah, that's a great segue into the drug interactions didactic. So this one was kind of, it's backed by popular demand. It seemed to be received pretty well last time. Everybody liked it. So I made some adjustments and added some things to it. But we're just going to look at, you know, the most common things that I see as a pharmacist in the specialty pharmacy, looking at these and seeing, you know, the other concomitant medications our patients are taking and how we can work around it and what those interactions are. And if maybe we could just use different agents. So I'm primarily, what you're going to notice is that I'm sticking with these top four: the Harvoni, Mavyret, Epclusa, and Zepatier, since those are really the four main direct-acting antivirals or DAAs that we see. And the first one here that problematic group is the statins, which we kind of just touched on with the pravastatin. So I tried to keep it in this nice chart to make it an easy reference for people to look at when, you know, they have a patient taking a statin and then they want to start them on a DAA. So you can see the most common problematic statin is rosuvastatin, having the most interactions with all four drugs. Actually not recommended with Harvoni, and then there's max doses with the other three agents here. The other thing that you'll notice that's kind of problematic is the Mavyret and the Zepatier. They're the ones that are the common offenders as far as our Hep C treatment goes, and that has to do primarily with the fact that they have protease inhibitors in them. Put some, you know, protease inhibitors in general, whether it's Hep C or HIV, tend to have a lot more drug interactions associated with them because they tend to be a little bit more inhibitory from a metabolism standpoint. So that's the main problem we see here that I have listed, is that you're going to have increased statin concentrations with these drugs because they're inhibiting whether it's the CYP system or the P-glycoprotein, and that puts patients at increased risk of toxicity. Specifically, what we're worried about is the myopathies. So you've got a couple of options looking at the chart. You can either change their statin if you want to look for something that has a little bit less likelihood of reacting, if you don't want to take the patient completely off of statin therapy. So something like the Prava or pitavastatin generally don't have as much from an interaction standpoint with these. You can lower the dose like the recommendations are on here, or just hold the statin like we talked about with the case. If it's somebody that doesn't have a significant cardiac history and their cardiologist or PCP is okay with them holding therapy for 8 to 12 weeks, that's an option that we do commonly for these patients. And then the next group, I always joke that this is the easiest chart that I ever have to make, but unfortunately this group is also some of the most problematic. Because the same four DAAs here, and we're looking at these four problematic anticonvulsants that are chronically an issue. The problem with all of these is that they're opposite of what we saw with the statins. So these are inducers of enzymes, primarily the CYP enzymes from a metabolic standpoint. So they decrease the concentration of the DAAs. So in this instance, the concentrations of the DAAs are going to be subtherapeutic, and then the patient risks virologic failure at that point, not getting cured from their treatment. So the good thing is that these are older treatments, so we don't see them as much used, especially the phenobarb and the phenytoin. But we do still, I still see a lot of patients that are taking the carbamazepine and the oxcarb as well. So the only option we have here at this point is to work with whoever the prescriber is, behavioral medicine or their neurologist, and see if they could possibly be transitioned to another agent that doesn't have these interactions. So I've listed 3 of them down here: the levetiracetam, lamotrigine, and valproate. There are some other options, some of the newer medications as well that are also okay. Gabapentin, not a newer one, but it's okay. No real major interactions with that one. Leucosamides, topiramate, pregabalin, those ones are all okay. I'm primarily just wanting to draw attention to this one, that it's a hard no. We do have to transition the patient from these medications in order for them to be successfully treated with any of the direct-acting antivirals. And then the other big problem, everybody is on some sort of PPI or H2RA, some sort of acid suppression. So our primary culprits here that we worry about are both of the drugs made by Gilead, the Harvoni and Epclusa, and it's actually not the sofosbuvir, it's the other agents in those. So for Harvoni, it's the ladipasvir, For Epclusa, it's the valpattinosphere. And what happens is as the pH increases or becomes more basic, the solubility of those drugs decreases, so they don't dissolve, and they're not able to get into the patient's body as well. So I always tell patients your body needs the acid in the stomach for this medication to really get in your body and to work. So we have a couple of options again for treatment with these. So you could not use these. So Zepatier, Mavorite, Vicira don't have this concern with changing the gastric pH. So you could use a different agent. You could completely hold the PPI H2RA in that instance. So trying something, a trial of not needing it. Sometimes patients don't know why they're taking it. So this is the opportunity to get them off something and see if they don't need it in the long run. Or you can make some dose adjustments. So that's what I have on the next two slides here is with each drug, what the recommendations are. So in this chart, this one is focused on Harvoni. And this information, recommendations and max doses come directly from the package insert. And then I've listed the comparable doses here as a reference to give you, because they say in the package insert comparable doses, but they don't tell you what those are. So I've tried to list those out here from a reference standpoint. So up here is your run-of-the-mill over-the-counter antacids, Tums, Rolaids, what have you. And these ones, it's a lot easier to manage if a patient's just using these kind of as needed because they're short-acting. So all you have to do is separate by at least 4 hours. So if I have a patient that says they regularly, are taking Tums or something at dinner time or after dinner, go ahead and take your Harvoni in the morning or lunchtime, and then there's plenty of time in between that administration and then the time when you're going to need those Tums if you do need them. It gets a little bit hairier as we go down the chart here. So the H2 receptor antagonists or H2RAs, we do have specific doses and administration instructions for them. So famotidine 40 twice daily is the max dose that's recommended in the package insert. So the directions depend on, how they're taking it, whether it's once or twice daily. So they have to take them simultaneously or 12 hours apart to avoid that interaction. So based on the pharmacokinetic studies, when they did that to see, how are we going to avoid this interaction? When is the pH going to be the most acidic? Either taking the Harvoni and that famotidine at the same time or separating it by 12 hours. And you can see the comparable dose here of the ranitidine if you can find it. It's mostly been pulled from the market at this point. And then PPIs in this part here, it's simultaneously with the Harvoni on an empty stomach. So now it kind of plays into, changing their routine a little bit where they, if they would normally eat with their medications, this is something they'll have to take on an empty stomach at the same time. So the max dose here is the omeprazole 20 twice daily, and they do have the comparable doses that you can see here. So this changes a little bit when we get to the Epclusa. And technically, this is also true for Vosevi as well. So for this one, you can see the antacids and the H2RAs, the dosing recommendations are the exact same. Where it changes is with the PPIs. So they actually have specifically stated in that package insert not to do it. If you can avoid the PPI altogether, try to avoid it. Try to get that patient to stop it. But if you absolutely have to keep them on a PPI, it is omeprazole 20 only. They didn't study it with any comparable doses, so they don't recommend any of those comparable doses like listed on the last slide. And they have to take the Epclusa with food and then take that omeprazole 4 hours later. So that one's a little bit harder to finagle with patients and trying to make sure that they fall within that window. But there is a way, if they absolutely have to continue taking their PPI, this is the one way that you can avoid that interaction. And I've had patients successfully do this and achieve SVR, so it is doable for sure. The next one that I kind of try to focus on and pay attention to is the ethinyl estradiol, and that's because with the DAAs, we don't have a huge amount of data with pregnancy in these patients, and we're treating patients that are now in the last several years of childbearing age, now that we're able to get these approved through most of their insurances. So obviously we want them to be on a reliable contraception, and ethinyl estradiol is by and large in almost all of the combined hormonal contraceptives that are available. So this is primarily an issue we see with Mavorite as far as our use here, also an issue with Vicira and Vosevi. So what they found is that the ALTs increased significantly when patients were started on their DAAs while concomitantly taking something with ethinyl estradiol in it. And then once they remove the medication, then their ALTs return to normal. So it's actually recommended to avoid using these together. So you've got some options. Don't use one of these agents if your patient is taking a combined hormonal contraceptive. You could use the Harvoni, Epclusa, Zepatier. Those are all options if your patient is taking something with ethinylestradiol in it. The other option is to hold the ethinylestradiol, but again, I'm worried that patients are going to become pregnant while on these agents and not really knowing if they're fully safe, not having that full clear data. So I'm not a huge fan of that myself, but always, if that is the one option that's available, abstinence or, barrier methods and other forms of contraception to avoid getting pregnant. And then the last option would be progestin only. So the good news is that a lot of our long-acting contraceptives now are progestin only. So using the depot, the implants, those are options, and those are perfectly fine. They're progestin only. Even the mini pill, the progestin only pill is an option for these patients as well. So you can use other agents or one of these other recommendations to try to avoid that ethinylestradiol issue. The next group that I have on here is the antiarrhythmics. The two major ones that we're concerned with from that standpoint are digoxin and amiodarone. So with digoxin, it's primarily what we've seen, what we're concerned with is Harvoni, Epclusa, and Mavorite, because they inhibit that P-glycoprotein pump that would normally kind of pump this stuff out. So inhibiting that means the digoxin concentrations can increase. And what we're worried about is that narrow therapeutic window with digoxin that we see and putting them at risk for dig toxicity. So the recommendation really is just to monitor those patients more frequently. I've absolutely had patients take one of these agents while on dig, and their cardiologist did just monitor their dig every couple weeks while they were taking it to make sure that they didn't go toxic and make those adjustments if needed. So it was fine. Just something to keep an eye on. Or Zepatier is an alternative. Doesn't have any inhibitory action on the P-glycoprotein, so it's an option if if you're a patient, if you're not sure the patient's going to go in for dig monitoring or that's just a concern for you, the Zepatier would be a good option in that respect. The problem with the amiodarone is all sofosbuvir. So any of your regimens that contain it, so Epclusa and Harvoni primarily, what they found post-marketing is that there were some events of life-threatening bradycardia. As far as I know, I haven't looked at the data in a while, but there was one patient, one death from bradycardia while they were taking concomitant sofosbuvir. So there were also case reports of patients needing pacers. So the problem is that amiodarone has a crazy long half-life, often quoted somewhere in the realm of 60 days. So the question is, if they come off amiodarone, when do we start? Even more complicated by the fact that amiodarone is a liver-handled drug, so that half-life is extended if they have significant liver impairment. So your options here are to use something else, so something that doesn't contain sofosbuvir, which you've got choices now, Mavorite, Zepatier. Those are options for you. And if you do decide you want to stop the amiodarone and change them to another antiarrhythmic, make sure to carefully consider the kinetics there with that long half-life. Prior to having all the agents available, we did transition patients from amio to other antiarrhythmics, and the package insert does not give any guidance on how long to wait when you change those. It's really just up to you. The only recommendation they have is to essentially admit the patient for monitoring, which I don't think any insurance would pay for or anybody really wants to do. So as a rule of thumb, we usually waited at least 4 months after they stopped amiodarone before even starting any sofosbuvir, just to give them at least a couple half-lives for that to be potentially removed, and then just monitor the patient carefully. One of the things I added based on conversation last time is looking at MAT. So these drugs are good with all of the direct-acting antivirals. So this is not a concern of any of your patients that are on MAT, whether it's Suboxone, Methadone, whatever, they're fine. No clinically significant interactions that are concerning us for their DAAs, no changes to that treatment. And also some of the drugs of abuse, whether they're illicit drugs or legal drugs, I've got the list here for the ones that are not clinically significant. So if you do have a patient that is an active drug user, from a clinical drug interaction standpoint, with amphetamines, cocaine, heroin, ecstasy, cannabis, LSD, no drug interactions there from that standpoint where you're concerned of interfering with the efficacy of the DAAs. But the caution that we do have is with fentanyl and GHB, because of the narrow windows there, the DAAs, primarily Zepatier and Mavorite, can increase those. So I know that one of the concerns that we've talked about, is with the opioid epidemic here in Appalachia and things being laced with fentanyl, causing some overdoses and concern. So if you have patients that are actively using, that would be the main concern if they're on Mavorite and Zepatier, is that if they would come across any fentanyl or GHB, that those concentrations can be increased by the DAAs. So putting them at risk there. The next group is anticoagulants and antiplatelets, because those can be scary anytime you're worried about drug interactions with those. So what you can kind of see across the board here is the majority of it is just monitor, which always makes me chuckle, because I mean, some of these things, other than warfarin, you can't really. There's no monitoring. You just tell the patient, like, if you're bleeding and you can't get it to stop, that changes nothing. You do all the same things that you would normally do if you're bleeding, and then just make sure they know signs of internal bleeding with headaches and the stomach pains and things like that. So the only one that's a no-no is Mavorite and dabigatran, because of the increased with that P-glycoprotein PGP inhibition, increasing the dabigatran levels a lot. That puts them at an increased risk of bleeding that, according to the package insert, is not worth the risk. So they don't recommend using those two together. But the rest of these, by and large, are going to be monitor. And I feel like with warfarin, that's really more of an art than science from a dosing standpoint sometimes. So we always recommend anytime they're using these agents, try to follow up and monitor a little bit more closely, just to make sure your INR stays within that range. And then I have this slide in here for completeness. I never recommend anybody try to memorize this slide ever with the antiretrovirals, because there's a lot of things to kind of look at and go through, and people are on so many different combinations of regimens for their ART therapy. So anytime there's a patient that has concomitant infection with HIV, always just kind of go to this list here. This chart is directly from the guidelines. I have the link here so that you can look and see what is my patient on, and then which drug is going to be the best option. I think the thing that we point out the most here is with the older version of tenofovir, the TDF, where we're worried about using that primarily if patients are on a boosted agent. For their ART therapy, just monitoring their kidney function a little bit more closely. I know that the group here has seen this, and with the older versions of tenofovir, we just kind of monitor their renal function a little bit more closely to make sure that there's no issues, no injury from a renal standpoint. But by and large, the newer version, the TAF, the tenofovir 2.0, we don't really worry about that as much in that version. So I always recommend just come to the specific HIV section of the guidelines and look and see what's my patient on, and then which of these therapies is going to be the best option for them to avoid interactions and issues. And you've got, like I said, you can see the green here. I modeled all of my charts off of this one. So green means go. Paw Patrol from my kids. So those are your options. And then last, herbals. Herbals always give me, the heebie-jeebies, because we never really know how any of those work, what those potential interactions are. So with St. John's wort, the good thing is that it's been around so long, we actually know that it's an inducer of those CYP enzymes. So it's a no-no for a lot of drugs, and the DAAs are included in that bucket. So puts patients at risk for virologic failure from subtherapeutic levels. So we avoid that with all of them. Think of it almost the same as the anticonvulsants. It's not okay with any of those agents. Some of the other more common ones that my patients are often on are the melatonin, milk thistle. A lot of them ask about grapefruit and grapefruit juice and turmeric. So those ones are all actually okay as far as we know. There's no clinically significant interactions in the way that those are metabolized where we're super concerned with the DAAs not working or getting any sort of elevated levels. So as far as we know, those ones are okay. But by and large, when I have patients and tell me that they're on herbals, if they can stop them, I recommend that they just hold off. It's only 8 to 12 weeks, just to make sure that there's absolutely nothing that's going to interfere with their DAAs. And then lastly, I wanted to put the slide up here with some of the resources that you can use to be able to check the drug interactions. The AIDS Info website has a lot of as a specific HIV Hep C chart where you can do very similar to what's in the guidelines to evaluate the patient's concomitant medications there to avoid. And then I really love the University of Liverpool chart. I always like make my students download it and make them, you know, utilize that when looking at drug interactions for patients, because not only does it give you where the interactions are, but it tells you what it is and if it was actually studied and what happened. So I've just got screenshots here where you can enter in, you know, whatever your therapy is for the patient or what you're leaning towards, and you can pick multiple. So if you want to evaluate interactions with the Mavorite here, you could scroll down, there's Harvoni, Zepatir's on here. So you can pick multiple ones and then enter in the next slide or in the next screen all of your patient's medications, and then it'll give you basically red, green, or yellow as far as what that interaction is, and then it'll give you the specifics on that. So, you know, what the recommendations are, what that drug interaction is, and then what the concerns are. So I always make them download it and utilize that, because I think it's a really good resource than a generic kind of drug information resource, which sometimes doesn't give you guidance on clinically what is relevant and what's not. So that's all I have. So I'm happy to take any questions.
Thank you so very much. That's very interesting. And thank you for supplying those last slides. I will make sure that, you know, your slides are in the recap so people can take advantage of that. And drug interactions is just very interesting, especially in today's age. I'm not gonna lie, there's so many supplements out there that say they can do this and that, and you don't know how it's gonna react. And I think even though it says natural, I think a lot of us have to be reminded that that doesn't always mean it's safe. So thank you again
Absolutely.
for that reminder. Does
Sure.
anybody have any questions or comments that they want to include?
Great job, Rachel, as always.
Thanks.
Awesome. I love it. Do this every year.
This is literally my life. This is like my favorite. I know it's like super nerdy, but this is the exciting stuff for me. This is what I nerd out on.
Yeah, no, it's super helpful, and I love the tables in there too. It's really helpful. Thank you. And it's always a good refresher too.
Sure.
And feel free to ask questions in the chat too if you'd like me to ask for you. That's completely understandable. Dr. Pollywall said thank you. Thank you so much. That's encouragement. And then I love those little like clappy, exciting little reactions. I don't know why, I just love them. So always use that or raise hand. But if we don't have any questions, I can go ahead and do the final announcement for today. Our next session will be on May 13th. And Dr. John Gilfus will be discussing when HCV treatments are deferred. So we really look forward to that discussion. As always, if you have any other questions, please reach out to me and I can reach out to Rachel and ask her, and I will make sure I have everything in the recap. Again, Jessica, you did a great job. Don't be shy, submit more cases. And as always, I look forward to seeing everybody later. Thank you so much.